Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
I'd like to share with you a case that we had here at our organization that was 6 years in the making. And this was an interesting case for us. Started off as a very complex medical case that turned into a social discharge planning issue that stood the test of time for us. And so I'll start off by just giving you a little background of the medical care and kind of would love to hear your thoughts as we kind of get through some of this. But our patient was a migrant worker who was here kind of going through the state, finding odd and end jobs working on farms because we have some pretty rural areas by the hospital. And one day he was living in a shed with no electricity, no water, just kind of squatting there. And his kind of roommate that was there with him noticed that he was not real responsive. So he called 911, and he was picked up by the ambulance, brought to the emergency department, and found to be septic and was really ill, ended up going to the ICU where he required a lot of intervention. Interventions included, he's intubated, he was on pressors for an extended period of time, antibiotics, full team approach when it came to surgical staff, our infectious disease providers, hospital medicine, cardiology, nephrology. I think we had every service we could offer at some point just based on his presentation. But he continued to worsen. And as you kind of expect, he had no decision maker through all of this. We had some, what we quote unquote called family that would arrive occasionally, especially on the weekends at night when they thought no one would be here to visit him, but never provided any information, never provided a name or number. And so we eventually ended up going through the court system to get a decision maker appointed for him. And so this is where things start to get interesting. And this is where I would love to kind of get some of your thoughts at first. We, after appointing or having the court appoint this decision maker, we noticed that due to the extensive use of pressors, that he was beginning to get some gangrenous areas in both his hands and his feet. Now, at this time, we had up to this point, no decision maker. So we were doing everything possible, but also we had no identification information, no ID, no name. We named him ourselves and really didn't know where to go or how to get resources for him at this point. And so my question, and sort of a kind of a roadblock that we hit, is what would you in your practice, as you're maybe caring for a situation like this, what would you have done since you couldn't ID him? You notice that you're starting to get this gangrenous, these spots on his hands and his feet, knowing that he didn't necessarily have anybody to make those decisions. How would you go about that within your own practice?
I mean, I am intrigued that he had people showing up. So someone knew him, someone, probably knew him as a person, maybe his wishes. I just keep wondering, was there an opportunity there? I'm sure the people showing up were probably scared, knowing that he, who knows what immigration status was. There could be concerns around that. Also probably very concerned that maybe they would financially be responsible for this situation, especially if they stepped up, there was any information. So my head is just going, how can we strategize to try to connect with that family? Maybe there's some language barriers, and make sure that they knew it was safe make sure that we want to connect with them so that we can try to understand what this patient's wishes might be. And I don't need to mention how old he was, what other medical issues, because I don't know, this sounds like this could be going in a direction where, gangrene, often leads to amputation. And I don't know if he's extubated at this point, like what quality of life, and really being able to sort through that. So I guess that's my thought, is like, could we try to connect with whoever's showing up in a different way? And Sweta, what are your thoughts as a longtime hospitalist?
I think I agree with you, Rebecca. My initial thought was, okay, fair enough, family is coming in the weekends, at nighttime, but nursing is there 24/7. So there is an opportunity there where we can put in the board. We usually have whiteboard in the patient room, and nurses, we pass along the message or make sure there is a clear communication and plan. If any family member or friend seen, they can go in and talk and at least ask for basic things that we need, like patient's name, date of birth if unknown, so that we have some starting point, as well as, like Rebecca said, some reassurance that this is not going to go against them or they won't be held account, like financially. And a lot of times it can be hard for nurses to have all that conversation, and there can be difference in comfort level. So we also have on-call social worker who is present in 24/7 in emergency department for these rare cases. So our floor is also covered by ED social worker. So ED social worker can come and help us getting all that relevant information and moving forward. I would also at this point like to say we have what we call ACMT, Advanced Care Management Team. So when it gets beyond your usual case manager or social worker case, like these complex cases, we involve our ACMT team who has a little more experience dealing with similar patients when it comes to like, hey, what are the next steps? Would you reach out to, again, if we can find any information? That sometimes we've had patients who were immigrants, they were legal immigrants, but they filed for asylum and they got the green card, but the green card's missing. So we had to almost reapply for the green card, get in touch with the immigration officer and the office and start the process. So it gets a little bit beyond like what does exactly needs to happen. So having that expertise or someone who can focus more on these high care need patients would be helpful, especially from gangrene standpoint of view. That's the second part. Now, the timing, it's not just disposition decision, like who will take care of the patient after. It's more time sensitive. I'm also, as a hospitalist, thinking, I hope what's the plan for court status? Did we get the court to help us make that decision as well? And if we don't have, if a patient's not able to make a decision, then even though we have a court-appointed guardian, they cannot make a decision on hospice. That still has to go through court. So are we at that point? Do we know what are our timelines? What is our prognosis? Do not know how long it takes at your place, but at our place, when we have to go to court, it takes, and for guardianship, it takes anywhere from 4 to 8 weeks to get a court appointment. So that makes it a little bit hard to just say, okay, let's put in a request again to court to make a goals of care discussion. So things that we have to keep in mind as well. So at this point, if I'm the hospitalist taking care of this patient, my initial thought is if the patient's having a gangrene, I would like to do a goals of care discussion, but that will take time. So we'll have to medically treat and use the court-appointed guardian for all the consent purposes, while getting clear prognosis from all the consultants.
Yeah, and that's a great point. For us, it takes approximately 6 to 8 weeks to get into the court system, get someone appointed. And so those were conversations. And I think this is a good time to point out the ethics committee, getting that group involved to ensure that we're really doing what's best for the patient and trying to understand where their goals of care were. Part of that, from that ethics committee, and y'all made great points, was trying to collaborate with who we thought were family. How can we meet you where you are? Are there opportunities? We offered to discuss that even outside of the hospital if they felt more comfortable, so that we could get his wishes, his first name, try to learn those things about him so that we were taking the best care of him. Not to spoil the story, but we did eventually find out that these were not family. These were actually other people that were working in the same farm that he was working on, who were just concerned, which was great to have someone concerned for him. Eventually, what we found out is they didn't have much information beyond what we had. Any money he had was stolen, and then his ID went missing. So we were really kind of left with nothing. So we did have a court-appointed curator that was able to make decisions for him, which did help in the case moving forward. But this is all within the first probably 2 months that he was with us. And so once we got the court-appointed decision maker, he began to improve. Around that time, he was extubated. He was able to communicate somewhat, mostly Spanish speaking. So we would bring in an interpreter for a couple reasons. This was something that we found interesting. We would bring an interpreter to help with the conversations taking place with him about medical decisions, helping him understand, but also for socialization. Because what we found was we here at the organization don't have a large Spanish-speaking population when it comes to employees. And so it gets isolating for someone who's in a room for this long without someone to speak with. And so we found that having that on-site face-to-face conversation really helped that socialization. So that was an interesting kind of lesson learned that we took away from that. But anyway, I digress. We continued to care for him. The gangrene progressed, and he was extubated. He knew what was going on. He was talking to his decision maker that was court appointed. He had some confusion throughout his entire stay with us, so we knew that he didn't always quite understand everything, but we wanted to involve him in those decisions. As the gangrene progressed, though, both hands and feet, the decision was then made that we had to do something that was going to be drastic. Dr. Severe, I think you mentioned usually that leads to amputation, and eventually for this patient, we had to amputate both hands and both feet, and that created a very hard situation for him. Going into surgery, told the provider, "Please don't take my hands. Please don't take my feet." So he had some understanding. However, his decision maker, who was a retired physician that was court appointed, made the decision for his health. That was the only way we were able to prevent the continuing spread of the gangrene. So I'll kick it back to y'all and ask, in that situation, that's a lot of ethical considerations. That's a lot of, prognosis and care decisions being made. How would you approach that situation? And from a social perspective, how would you approach that?
I guess, it's hard without being there to understand what the patient's really understanding. Because sometimes, if you have patients who are completely competent, like if I can't have my hands and feet, this is not quality of life for me. And I don't want that done. And we have diabetics all the time that will risk their life and they will not have, the leg amputated, for example. And that is their choice. And you do the best you can. But it sounds like you guys were not confident that even though he's saying that he fully couldn't think through the implications of not having it done. And I was also intrigued by the translator bit, because we have patients that speak all sorts of different languages. And it's usually a little iPad, translator. And I find that we have a lot of trouble with that. Sometimes it works fine, but the more confused the patient, hard of hearing, it just doesn't work. And those patients, I like how you point out, it's very isolating. And so I think even if you have translator services, that your translator services may not be optimal and still not connecting. But it sounds like you were able to get in-person translators to really have the best opportunity for effective communication with this gentleman. And did you feel like sometimes I've also had experience with the guardians, like, I don't know, the conversations, some of them are paid to do this, their level of engagement, I've sometimes found that part challenging to help navigate, just because you feel like they're not helping you out and getting into the sorts of conversations you would like to have. Was that a barrier for you too, or was that part actually going well?
So that is actually going really well. And we've had that same consideration in other cases where we've seen kind of the same idea. Okay. Because he had no income, and we as an organization, when we went to court and he was appointed the decision maker, there was no request for payment because he was a retired physician. He was kind of doing it sort of out of the good of his own heart, in his opinion. And so that made things easy because he wanted what was best for the patient, and it wasn't worried about financial considerations, which was
that's great.
A nice kind of breath of fresh air in those situations. So the socialization part, that's, I think, and, like I said, he was here with us for a little over 6 years, and that became having that on-site interpreter. We had one agency that provided 2 people specifically for him. So he knew them and was able to communicate with them. That made a big difference for him in his quality of life. Because at that point, that's what we were worried about. So he did have surgery. We did the amputations, and he healed really well, and actually did really well after that. And that sort of, when he went into surgery, there was questions about how would he do post-operatively, especially given his level of illness and kind of how advanced the gangrene had gotten. And so he did really well, was in our surgical ICU for a little while, extubated not long after. His wounds healed well, and he was able to transition to our med-surg department. And that's where he sat for approximately 5.5 years, getting routine care, which was not the plan, but as you know, with discharge planning, there's a lot of considerations with someone who doesn't have a Social Security number, doesn't have an ID, is unable to get any kind of assistance anywhere, and doesn't have, the ability to get into a nursing home or something like that. So I know there's a lot of programs across the country that in different states have different programs. I would love to know what you use or what systems y'all put into place for these kinds of patients that don't have access to those kinds of resources.
Jason, can we backtrack a little bit?
Sure.
I was just curious on a couple of things. Firstly, I want to say I agree with Rebecca and you. The in-person translator works much better than phone or iPad. And that's why even as a hospitalist, when I'm having any critical decision-making or discussion, or for my daily rounds, I request for in-person. We do have a pretty diverse community here, so we are able to get a lot of times, and especially because there is variation in dialect, which makes it a little bit harder to just use phone or the tablet, and that with in-person is much easier for that. You can specify the dialect. In any of those conversations, did we ask or did we get more information about the patient? Was he able to tell more about himself? Where is he from? What does his family look like? And even if not here, like you mentioned, he's immigrant, so back home, what is the background? The reason I ask is, one of my other thoughts was, okay, so it seems like he does not have a family here, but he could have a family overseas who could help with at least be part of the discussion and be involved in the care and help make sure there is an understanding, or at least some figure out some support system over there.
Yeah, I was gonna say, to me, like usually the only resolution for a case like this is you have family that can step up. So you got to figure out where that family is, or you have to have some sort of charity care, usually funded by the health system. Like I don't know, that those are the only options that I've experienced for patients similar to this. So
I've actually seen another option too. So that's why I was asking these questions, because before I jump into 3 different things I have seen, I wanted to hear more in terms of if we heard anything about the family.
So we continued to search for family using information we had. He actually preoperatively, before the amputation, refused to give his name. And so we asked him, based on the information we had from those that were visiting, is your name, is this what your name is? And he would neither confirm nor deny, and he would actually use different versions of that same name. And so as we continued to work with him through the interpreters, we determined that he actually had some level of dementia and confusion. He was probably in his late 60s is our estimated age. So that continued to progress over time, which made finding family more difficult. Going back though to the interpreters, and I think that's one of our biggest learnings, and you've experienced that as well, I see. Having the in-person interpreter built for him relationship. And so we were able to learn things through some of the conversations he had because he was more comfortable with the interpreters. So we would sometimes have nursing stand outside the door to get some ideas of what he was saying, or she would come out and report to us, these are things he's talking about. And some of that was about war in his country. And then we kind of placed that based on his age or expected age, and then tied that to what he was saying about the war. And so we kind of started getting ideas of where he was from that, as well as maybe that helped us define his age a little bit better. But we never got a true full story. And those that were visiting eventually stopped. They, again, were migrant workers. They moved on to other areas to find work. After about the first 8 months was no longer receiving visitors. We even at the point to where someone came to us and said, "Oh, I'm moving to California. I'll be happy to take him with me. I'm coming back tomorrow at 8 a.m. to pick him up." We were ready to send him. They never showed up. So, and then to your point, Dr. Severe, about having the charity care, we went through a lot of various options. To the point where we had an immigration attorney work with us to try to find his identity through either the immigration office, using information that we did have, his name. At one point, we had a stated date of birth when we kind of tied that to the conversations he was having. So we tried to use that information to really pinpoint who he may be. That was unsuccessful. I went to every nursing home that I could reach and said, "Look, we will cover his stay with you. If you can help move him along and get him out of our hospital, because it's not really the environment. And he's in a room, right? A very tiny room by himself." And that's where the idea or the issue with him not having a true identity, no picture ID, no birth certificate, no passport, no green card, no social security number, nothing. And so that really concerned our administrator, saying that, if they were to be surveyed by either a state or federal agency, they were concerned that we can't prove that he's even supposed to be here, and they just were not willing. So we hit a lot of brick walls. And that's what a lot of the first probably 2 years we spent really trying to find him, that kind of help to be able to get him out of the hospital, because it felt kind of cruel, unusual punishment, to be in a hospital that long in a single room.
Yeah. And it's very hard when you cannot find any identifiers, because I can see from SNF perspective, why would they be hesitant to take someone, even though hospital's willing to pay for it? There is possible risks, and I can see that. And like I said, if we had the family, then what we have done, and that's where I said we've seen 3 possible options. One is have family, even if they live overseas, come help with the immigration or give them the letters to supporting, like they need to be here to be able to take care of the patient. And then have been able to get support that way in terms of having a family member come to US to help out with the patient. Mm-hmm. Second scenario I've seen is we've had patient be sent back to their home country because they have more social support and family that can take care and help support with the medical flight, etc. And the third, of course, it boils down to then charity care. A lot of times, if they are, like you said, if they have the ID, they have the social security number, then we could request for those charity beds that some of these the other institutions have. Either SNF have it, or some of the hospitals or local hospitals which have tied in rehab beds that can be utilized as well. But it is very hard when you don't have any family information or patient identifier. Mm-hmm. So just out of curiosity, so patient stayed in for 5 years till he could physically move around and was getting wound care, rehab care.
So we gave him the full gamut, physical therapy, occupational therapy. We actually worked with a local provider to create custom orthotics that we provided for him to be able to begin to move. He hated them and actually refused to wear them after some time. And so really he became wheelchair bound, which he could maneuver his wheelchair on his own. He would help transfer in and out of bed. We tried our best to get him to a point to where, if we could get him somewhere, he would be able to take care of himself. At one point, the topic of, could we send him to a shelter, the homeless at this point? How do we manage that? But there's always concerns with his ability to make decisions and his fully understanding what was going on, his mental capacity. That, along with his really inability to be fully self-sufficient, because he refused to use orthotics for an extended period of time. So there were a lot of concerns that was kind of taken off the table kind of early. What we eventually ended up doing to kind of round out his story was working through several vendors. I spoke to several different repatriation companies. Is this somebody you think you can work with? Do you have resources to help us with this? And there was one agency that really came and spent some time with him, had their own interpreter who had some connection, who was able to put some of those pieces together about his own personal story that he shared about the war, and about family that he had that lived in a certain area and timing. We eventually found a birth certificate from Mexico, is where he was from. And we were able to get him back into the country, enrolled in healthcare services, and he actually went to a care facility in Mexico where he was then cared for afterward. So it was a much better ending to the story than we anticipated ever when we kind of started down this path with him. But it took a long time to get there. And I think some of that is another lesson that we learned through this was you can't stop. You have to always be looking for the next thing. Keep asking questions. Keep talking to other people, even though you may get an answer that's not favorable. Like when our immigration attorney told us there's no hope, we couldn't stop. We had to keep asking, keep having conversations, keep networking. And then eventually the pieces will fall together to get the care that he needed. And it was really great because he actually got somewhere where he was able to not only get care, get out of a hospital setting, but to socialize with those that spoke his own language, who understood his own culture. I think just it became a much better living situation for him in the long run. And then luckily we were able to follow up and hear that he was doing well about 6 months later.
That's great.
Yeah, that's an amazing story. Like I wasn't sure how this one was going to end, and that is satisfying that you were able to figure that out and actually get some identification. So that's a great patient case. So thank you for sharing that with us today.
Of course, I appreciate all your feedback.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. APPLCOM is inclusive of all practice settings. Membership in APPLCOM also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, APPLCOM membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
I think you mentioned you have another case for us, Jason.
I do now. This is a real life case. This is something we're actually dealing with now, and I would love to get some of your, as physician advisors and providers, kind of your input. We have a patient who is a 60-year-old female that came to us who has a really complex medical history. Coronary artery disease, hypertension. She's had previous strokes, also a history of drug abuse and congestive heart failure. And she presented to us with sharp chest pain, shortness of breath, a lot of complaining of orthopnea over the previous 2 days. She also complained of worsening just a productive cough. And so in the ED, we worked her up and found out she was hypotensive, a little tachycardic. She was a little tachypnic, but her SATs remained normal on room air. Above 95% actually. So we did some lab work. She had some leukocytosis, a really elevated BNP, and her chest x-ray showed some lower lobe pneumonia. So in the ED, we actually started her on some IV Lasix, some broad spectrum antibiotics, gave her some nebulizers, 1 dose of steroids, and then they decided to put her in observation just to kind of see how she responded and determine, would she bounce back fast enough to go back home. Knowing her history, this was not an unknown patient to our emergency department. She'd been several times before. So they kind of thought she'd bounce back quickly. So during the obs period, though, she continued to have this really sharp chest pain, So we consulted with our cardiology group who did some workup and diagnosed her with pericarditis. And so that's, as they continued to work up for that, they started her on first line medications to treat that. But it was the next day after they started that, so hospital day 2, that we noticed her creatinine begin to rise. And we were real concerned with her because of her history of heart failure, really grossly elevated BNP. We knew that fluids were going to be something we'd have to really monitor and manage closely. That with the change in her creatinine and some renal issues, our provider decided to change her to an inpatient level of care. And from a UR perspective, we felt like that was a confident decision. Based on your history, how would you kind of read into that situation? Would you agree with that, or would you think observation would be more warranted?
I think it's inpatient. This is one, just with the history, I might have even, if someone made it inpatient from the start and it came to me as a physician advisor, I probably would not have downgraded it. This patient, they're going to have problems. They have a high potential of it. So I would have probably blessed it to stay inpatient, but definitely if it came to me in hospital day 2, I would have recommended the upgrade. The thing that is going to help you get that to stick, and usually I'll reach out to the clinicians when we're asking for that upgrade and say, please make sure that on each day you're documenting patient's symptoms. Like, are they still short of breath when they're up? Because a lot of times the vitals will look good. You'll have a perfectly normal exam. You won't have true desaturations. But I will ask them, like, it's critical. Like, are they still having that orthopnea? How about when they get up and walk, are they still short of breath? Because if you can't make the case that they have symptoms, then it looks like they should go home. Same thing with that chest pain and a pericarditis. I'd want to make sure that every day the clinician's saying what is still there. Not that they're better, because if they say they're better, that means it's all gone and they should go home too. So those are kind of my thoughts on hospital day 2. Sweta, how would you handle it?
I agree with you, Rebecca. A lot of time it's not just about if they are improving or not. It's about, is the systems persistent and limiting them from going home? Because fair enough, we don't always wait for everything to go back to baseline before they got ill. But at the same time, if they're still persistent or significant enough that they cannot be discharged safely, that gives us enough strength. I would have also upgraded to inpatient because, one, we know this patient, we tried observing and seeing if things improve, we can get them home. If not, and they need to stay medically, and things, if anything, are worsening or new problems coming up, which is new creatinine increase, that needs in management and monitoring, along with close fluid management. Even if we do nothing in terms of, we cannot give IV fluids because they have heart failure, we cannot give them IV diuretics because they have an acute kidney injury. So rather, we want to just hold any diuretics, hold any IV fluids, and recheck the labs. That is also not something we can safely do as an outpatient. So agree with the inpatient and agree that we need strong documentation supporting that dilemma that the provider is having, and that we do intend to do interventions, but our options are limited. We are considering, and that's why we need to keep in hospital, so that if things worsen or if we need to give back the fluid, we have that ability to do that.
And I'm glad you all feel that way, because we felt the same way. We really felt like this was inpatient. And I agree, as a nurse looking at it, using any type of criteria or just really kind of that basic initial review, I was okay with observation, but really looking at it, understanding the complexity of this patient, I agree, inpatient from the start almost seemed appropriate. But, this goes back to, I think, a practice that a lot of UR nurses and departments look at, which is anticipating or trying to anticipate what the insurance company is going to do. And I think we were victims of that in this case, where we said, we know this is going to be denied as an inpatient initially, so let's get through the observation period first. So we can say they failed it, which is, we followed that. The problem, and this is where we are with this case now, is she continued to worsen to the point to where we were getting nephrology involved to discuss possible dialysis because her kidney function just was not returning and was getting worse. There was a lot of discussion about the appropriateness of her care or not the appropriateness, I shouldn't say that, but the best way to care for her because of the pericarditis. That first line drug has some nephrotoxicity. So how do you manage that treatment plan, but also manage the kidney function that was declining? And so we felt she was very complex and needed to be in the hospital. The second day after we made her an inpatient, though, she decided to leave AMA because she didn't want to be in the hospital any longer, which was not uncommon for this specific patient. But this case was actually denied for inpatient level of care by the payer. We went through a first level of appeal and peer-to-peer, and the denial was upheld, which has been interesting for us. We're going to continue to go forward with it. But I just, knowing what you know in your experience in talking and doing peer-to-peers and things like that, what areas or what things do you think would be helpful in really stamping that approval of inpatient on that, or getting that stamp of approval from the payer?
Yeah, and who did your peer-to-peer? Do you have devoted, physician advisors, or is it the frontline clinicians doing your peer-to-peers?
So we actually go through a third party for our peer-to-peers. I do have a devoted physician advisor, but she's also practicing. So there are days where she can't actually get in there and do them.
Yeah, I mean, I feel like this is one, to me, I felt like the majority of my payers, I would have gotten it overturned. Like, I'm kind of surprised you didn't. So sometimes you'll just get a medical director and they are just, I don't know, you just have problems with them. They're not reasonable. So I guess it depends on how good was that argument going forward. I felt like you pointed out enough clinical indicators to me that this should have had enough there. Like, you've got multiple systems involved, persistence of symptoms, and the fact that, patient likely, if they would have stayed with the appropriate course, they would have been a much longer stay. So even though it wasn't, 3-4 days, whatever you were, it still was beyond that OBS period of time. I'm guessing they're Medicare, just given what you described, maybe not. But, for Medicare patients, it should have met the 2 midnight, or it did meet the 2 midnight rule easily. And so you should have enough to argue it. Kind of surprised. I would still go after it, with the appeals. So.
Well, and that was our complicating factor. It's not Medicare, because the 2 midnight rule, we definitely, look at that. If this was a Medicaid plan.
Oh.
I would like to add, I think I'm not surprised this was denied, because we have seen variability in how peers look at some of these cases too. Some of them I've seen being stuck on the fact that they discharged in a short period of time, and then often we have to argue back or share, hey, this patient would not have discharged if was not leaving AMA. So bringing them back to, it's a patient-driven discharge and not necessarily a system-driven. So shorter length of stay is because of the leaving AMA, emphasizing that. Still, some of the providers' pairs can be decay, anything that's shorter length of stay, regardless of the reason, we call it as an observation. While, like Rebecca said, most of the time we've had very good interactions with the payer providers who will agree this is a complex patient, multiple systems, though not aggressive IV things happening, but at the same time needs care in the hospital, needs that duration, and would have had a complicated, longer length of stay if did not leave AMA and it was a patient-driven discharge, so would overturn. I think in your next level appeal, key points I would focus on is one, that the patient left AMA, emphasize on that. Otherwise, this would have been a longer stay with a lot more complexity. And two, if you have a patient coming back or have a repeat lab proving the point, that will be helpful. And also pericarditis or pneumonia, I'm guessing patient was switched to oral antibiotics, but pericarditis with an AKI, like you rightly said, it's a complex decision-making a little bit over there. And often I like to say, hey, sorry, I'm getting a little more hospitalist here. Giving colchicine will make them AKI. Giving them steroids for it will make their volume overload worse, because then they'll retain more fluid. So my options are limited, and that's basically putting down all the options and potential risks and how this is a high-risk patient to begin with. Emphasizing on that would be with the hope that now the payer will review and see and be able to approve that, given the complexity of the case, high risk of deterioration and patient morbidity and mortality.
Those are all really great points. I appreciate that. I think as we continued on this case, we're going to, I think, like you said, point out the AMA. That was actually the reason why we got the initial denial, was the patient was discharged the day after an inpatient order was placed, and they felt like it was too close, and despite the AMA. And so we are trying to correct that conversation, because really, like, as you've all pointed out, there was some complex decision making there that really did require the inpatient level of care, at least we feel like. And I think this is one of those things where we put our stamp on it and said, this is what we believe is an inpatient. We're not going to back down, which I think is important for hospitals to do. And so we're going to continue to push it forward.
Let us know what you find out and how does the next level of appeal goes.
I will.
Great. Thank you for sharing another great case. So appreciate you joining us today.
Thank you. Thanks for having me.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.